A warm welcome to all of you on the second day of Synapse 2022. We had a very interesting session yesterday and a lot of interactions, lot of mind-boggling discussions. And I'm sure today is going to be equally the same. So I request Divyangana to take over the proceedings from here onwards. Thank you so much.
Thank you, ma'am. Good morning, everyone. I'm Divyangana Patil, and I welcome you all to the second day of Synapse 2022. So we begin with the session that is the paper and oral presentation. So we have with us Dr. Vinayak Harale, sir. The session one is the paper and poster presentation. I call Sonali ma'am to proceed further. So we have Sonali ma'am. She is a MBBS postgraduate diploma in diabetologist from UK. She's a consultant diabetologist, postgraduate diploma in clinical endocrinology and diabetes from UK. She has a fellowship in diabetologist from UK. She is a director of Nectar Diabetes Center, Pune. She is the winner of Diabetes Indian Award 2021. And recently she has been awarded as the Maharashtra's Idol Award in 2022. Over to you, ma'am.
Thank you, Vaishali, for that kind introduction. So after the successful sessions we have been gone through yesterday, we start with the second day of Synapse 2022. First session is paper and poster presentation, and for which the moderator is Dr. Vinayak Harale, who is a eminent endocrinologist from Pune. He is MD Medicine, DNB Medicine, and DNB Endocrinology. DNB Endocrinology from PH Hinduja National Hospital, Mumbai. He's a consultant adult and pediatric endocrinologist, Supreme Clinic, working at Akodi, it's a Pune suburb. He's attached to Jupiter Hospital, Bane, and D.Y. Patil Medical College, Pimpri. He has done many oral and poster presentations and national and international endocrinology conferences. He's a life member of Endocrine Society of India. So with this introduction, I hand over the dais to Dr. Haran.
So there will be 8-minute time for the presentation and followed by 2 minutes discussion.
Sure. Good morning. My name is Naomi D'Souza. I am a clinical psychologist working in Pune, and I currently work as a research fellow in the KM Hospital Diabetes Unit Research Center. My presentation that I'll be talking about today is entitled "My Diabetes Should Go Away Forever," and the title will make sense later on in the presentation. It's a mixed method study of quality of life in children and adolescents with type 1 diabetes. So when we understand type 1 diabetes, it is understood as a disease that has an early age of onset. The treatment associated with it is very intensive, and the lifestyle modifications are also required, and they're also quite intensive. And what we're seeing is that patients who are essentially young people and their caregivers are having to adapt to these new lifestyles while also trying to maneuver around their own difficulties of growing up and understanding where their place in the world is and how to achieve autonomy for themselves. And when we look at what quality of life is, essentially WHO defines it as an individual's perception of their position in life in their context of their culture and the value systems, and in which they live in, and their relations to their goals, expectations, concerns, standards. And when we're looking at adolescents and children, we see that their immediate surroundings, their peer groups, and their family members go into making up what they can expect from their world and their surroundings. Now, quality of life of children and adolescents with type 1 diabetes has been found to be poorer than their controls. And it's important to talk about quality of life when we're talking about diabetes, since it requires such an individual's involvement in treatment and treatment outcomes. And therefore, the way a person perceives their quality of life does have an impact on how their treatment outcomes can work. And so therefore, the aim of our study is to understand the illness-related experiences of children with type 1 diabetes and how it impacts their quality of life. Since it's a mixed methods, for the qualitative aspect of the study, we are taking a narrative approach in understanding a child's experiences. So I've divided the methods section into two parts, the quantitative and the qualitative part. So first, the quantitative aspect. So children and adolescents were selected from the KM Hospital Type 1 Diabetes OPD. We have been treating them for a long time. So we had their socio-demographic information, illness-related information such as sorry, HbA1c levels, duration of illness, and we administered to them the quality of life questionnaire for youth. We used for this study the short form version of it, which is a 52-item questionnaire, and it assesses the psychosocial impact of diabetes on a person's life. And it scores on 3 domains, so satisfaction, impact, and worry. All the items are to be rated on a 5-point type Likert scale. And usually the questionnaire is scored such that satisfaction versus worry and impact go in, go in opposite directions. However, for the sake of our study and for ease of administration and scoring, we've inverted the scores, and so that all the scores can be scored in the same way and all have the same meaning. And therefore, higher scores indicate lower quality of life in our study. For the qualitative aspect of it, an open-ended questionnaire was developed. That questionnaire had 11 questions in it, and it was associated with the person's general diabetes experience. It covered questions related to meaning of diabetes for the person, how it impacts them, what are the factors that they're most troubled by in their diabetes, their support systems, barriers to treatment, how their finances affect their diabetes treatment as well. And the child could answer, so there was no limit, there was no word limit, there was no language limit on how the child had to answer. Since we're dealing with relatively younger children as well, so it was understood that the child should feel as comfortable as possible when trying to express themselves. For the sake of our presentation, I will be later on only covering 4 themes and 4 main questions that we've taken from this questionnaire. The analysis was done, so first the quantitative analysis was done using gender and age group divisions, and we looked at the significant differences using the Man-Whitney test. We also looked at correlations between quality of life and socio-demographic information using Pearson's correlation. For the qualitative part of the analysis, we had used the Max QDA 2020 software. So all the responses that were given were first transcribed into the software. And from there on, we developed major themes and sub-themes from what we were seeing in terms of their answer patterns. And then for later on analysis and for ease of understanding, we've looked at frequency and percentages and nature of themes, and we've compared them with by age and gender groups. So just as an overview, what we are seeing in terms of the socio-demographic distribution of our sample. So median age is about 13.5 years of age. There were more females than males in our particular sample. And for analysis, we've divided the groups into adolescents and children. So adolescents were those who were above the age of 14, and children were those who were below the age of 14. They were equally distributed in our particular sample. Most of the children had about 6 to 10 years, with 8 being the median age of years of education. Age of diagnosis was at around age 7. Duration of diagnosis was about for 5 years, and HbA1c levels were between 8.85 to 12.40. So now moving on to the quantitative aspect of the results. So what we found was that higher age is significantly associated with higher worry about diabetes and higher impact as well. And when we compared girls versus boys, we found that girls did report higher worry associated with their diabetes as compared to the boys. This was not significant, but it was at a 0.08 level. And when we looked at these graphs, what we noticed was that girls, like female adolescents, had the highest amount of worry and impact associated with diabetes. However, we found it interesting that satisfaction levels were more or less equal across the four groups. And so that means that even though the girls are reporting of higher worry, higher impact, they're not overall unhappy per se with their lives. Another interesting thing that we found was that HbA1c scores duration of illness was not associated with overall quality of life. And now when we look at the qualitative results, this helps us understand what are the particular themes that the child is bringing into the whole, bringing up for the results. So when we're looking at the most troubling aspect of diabetes, so that was one of the questions that we asked the child, and it was literally this: what troubles you most about your diabetes? So when we grouped them into themes, we found the themes were treatment related, restriction on lifestyle, and physical symptoms were some of the troubling factors that came up. And under treatment related, we found that dislike for insulin was a major complaint. They also disliked the constant glucose monitoring and the regular follow-ups. Under restriction on lifestyle, dietary restrictions again was a major theme that came up. And physical symptoms that they were in particular troubled by were things like low blood sugar, fluctuating sugar levels, and frequent urination.
Thank you, ma'am, for your wonderful presentation. It's very interesting to know that this quality of life is not being affected by the level of the HbA1c, whether the diabetes is severe or not, or the even duration of the illness. As the age increases, the worry seems to increase in the patient with type 1 diabetes.
Dr. Harley, is my presentation time done, or could I continue, please?
Yes, ma'am, it's done actually.
Okay, I didn't get any warning or anything.
Do you have any last slide to show?
There are quite a few slides, so if I can maybe then show the summary slide. So I think in our summary slide, what we found is that adolescents and females tend to experience higher worry about their diabetes, and that they have a greater impact of diabetes on their lives. Perception about the nature of diabetes and diabetes impacts lives differ between age groups. Perceived support also differs with age and gender, and majority of the participants reported wishing that their diabetes would go away forever. So that was a very prominent finding we had. I think one of the major implications that I would like to bring up is that so much of our treatment focuses on the medical aspect of a child's functioning. However, what the presentation showed was that their concerns seem to largely be associated with their restricted social interaction, their lack of ability to interact with their peers, and that was more important to them than anything else. So when we are talking about treatment and education of these children with diabetes, we need to consider this as an important factor affecting them as well.
Okay, thank you, ma'am. So we'll move on to the next presentation, oral presentation by Dr. Prince Garg. So Dr. Prince Garg is a final year resident from the Department of Psychiatry at MGM Medical College, Aurangabad. So she will be presenting on the correlation between psychiatric comorbidities and quality of life in diabetic patients at tertiary care center. So over to you, doctor.
Very good morning, everyone. Myself, Dr. Prince Garg. Topic for my presentation is correlation between psychiatric comorbidity and quality of life in diabetic patients at a tertiary care center. So background of the presentation, as we know that during the last few years, mental health disorder with chronic mental illness has become one of the most upcoming problems. Diabetes is one of the most mentally exhausting illness as it requires strict management of the treatment by the patients themselves on the daily basis. Poor sugar control may cause or exacerbate psychiatric morbidity by directly affecting the brain itself or indirectly through its complication, functional impairment, and can decrease the quality of life. Increased prevalence of psychiatric illness in diabetic patients points that evaluating the effects of comorbid illness on the quality of life in diabetes will have relevant clinical outcomes. So aim of the study was to study the prevalence of psychiatric morbidity and its impact on quality of life in the patients with diabetes. So the study included all the IPD and OPD patients at the MGM Hospital, Aurangabad, and it was a cross-sectional study design which included 375 diabetic patients with HbA1c value of 6.5 to 7%, 6.5 to 8% only. It was done during the October 2018 to 2020. The inclusion criteria of the study was the diabetic patients which were willing to participate in the study and who were willing to give a valid informed consent. And it, as I told earlier, it included the HbA1c value of 6.5 to 8% only. The exclusion criteria of the study were the patient below 18 years of age and patients who were already receiving the treatment for the psychiatric illness and patient with any other complication of the disease itself or other illness like hypertension, etc. So after taking the approval from the Scientific Advisory Committee and Ethics Committee of the Institute, patients were evaluated for the inclusion and exclusion criteria, and informed consent was taken from all the patients. Socio-demographic data and clinical details of the patients were noted. Lab investigation was included to check the value of HbA1c so that we can rule out the patients who were having the value of more than 8. And patients were administered mini screen version 7.02, which is based on DSM-5. It is done for the screening of the psychiatric illness, and the patients who were answering any of the question of yes, then they were administered the standard mini of the mini for the establishment of the psychiatric illness. And after the one of the psychiatric illness was diagnosed, then they were administered specific tools like Hamilton Depression Rating Scale for depression, Hamilton Anxiety Rating Scale for anxiety, severity of alcohol dependence questionnaire for alcohol use, Spin Social Phobia inventory for the phobias, and Yale Brown Obsessive Compulsive Scale for the OCD disorder, Young Mania Rating Scale for the mania, and the clinical administered scale for the PTSD for the PTSD disorder. And later on, the quality of life by the WHO scale was administered to assess the quality of life in the participants, and the data analysis was done later on. So result of the study was that majority of the patients, that is 146, had HbA1c value of 6.5 to 7%, and of all the participants, 21.6 were diagnosed with the psychiatric morbidity in our study. The majority of the patients with psychiatric morbidity had HbA1c value in the range of 6.5 to 7%, and the significant association was found between the HbA1c value and the psychiatric illness, which had p-value of 0.019. And socio-demographic profile suggests that participating population had a mean age of 55.04 years. And in our study, major depressive disorder were present in 34 participants, while panic disorder were present in 30 participants, alcohol use disorder were present in 11 participants, and generalized anxiety disorder in 3 patients, agoraphobia in the 2 participants, and the OCD, obsessive compulsive disorder, in the 1 participant. Among those participants with psychiatric morbidity, the mean score was higher for the above mentioned component as compared to those with the psychiatric morbidity. So this is a figure which shows the bidirectional relationship between the type 2 diabetes mellitus and the major depressive disorder. There are few factors which are associated with the diabetes itself which can increase the risk of the depression. One is the obesity, the stress related to the disease itself, and the coping strategies which are very poor among the diabetes and the metabolic syndrome. Similarly, there are few factors which are present in the depression associated with the depression which can increase the risk of the diabetes. One is the weight gain, lack of physical activity among the patients, and the use of antidepressant. As we know that antidepressant are used for a very longer duration and they itself has a side effect of weight gain. So there occurs a bidirectional relationship between the 2 diseases itself. So conclusion of the study was psychiatric profile suggests that 1/4 of the participants had psychiatric morbidity. Assessment of quality of life using the QLES scale, that is quality of life and enjoyment and satisfaction questionnaire, which expect the following points like physical, feeling, household duties, social relationships, and general activities, showed a statistical significant difference between both the group with the illness and without the psychiatric morbidity, thus stating all the participants who did not have psychiatric morbidity have better quality of life, enjoyment, and satisfaction in most of the aspects of the life. So these are my references.
Thank you, Dr. Prince, for your wonderful presentation. It's very important to understand that even those diabetic patients, those who do not have any psychiatric symptoms, but after all this questionnaire and findings, we know that the major depressive disorder, panic disorder, various psychiatric disorders are there in asymptomatic diabetic patient. So will you just tell us what is that mini screen version of 7.02?
Yeah.
Yes.
Sir, it is basically used to screen all the patients if you are suspecting any psychiatric illness in patient.
Mhm.
So it contains all the depression, anxiety, alcohol use, OCD. These are the few points it included. Whenever a patient, we suspect that any questions we give the patient, it is a clinician-based screening tool. If
Okay.
any of the answer is marked yes, then there is another tool that is standard mini, which
Okay.
include the different disease itself, like
Mhm.
OCD, anxiety, and depression.
Okay.
So there are specific questionnaires which contain around 20 to 30 questions of each disease itself. So it is assessed later on.
Okay. Okay. Thank you.
Dr. Prince, I would have one comment and one question for you. One comment is that it is a well-designed study, very well conducted, ethically approved.
Thank you,
Do
ma'am.
I have a question?
Yes, ma'am. Yes.
Yeah. So one question to you is this patient administered tool, any of these tools patient administered or all are doctor administered?
Ma'am, there is one tool that is quality of life and enjoyment scale that is given by WHO. That is patient administered scale. Patient themselves can administer that scale.
So was that, which was the easiest of the tool to perform in a clinical setting which is so busy? Of the scales that you use, which was the easiest to use for a diabetologist to use in his own practice?
Ma'am, Mini is the basic tool that can be used.
Okay.
And for the quality of life, there are two other scales by WHO itself that can be administered by the patient and both the treating physician itself.
Thank you. And congratulating for you finishing on time.
Yes, yes.
Thank you so much, ma'am.
Thank you. Thank you, Dr. Prince. So the next presentation is by Dr. Kiran Ambedkar. Sir is a Ayush medical faculty at working at the Podar Medical College, Mumbai. So sir will be presenting on the novel interpretation of HRV-based quantitative diagnostic and prognostic test in the integrated medicine, a pilot study. Over to you, sir.
At the outset, I thank organizers for giving me opportunity to present our work as a pilot study. Novel interpretation of HRV-based quantitative diagnostic and prognostic test in integrative medicine. We could see an opportunity to translate HRV indices to relevant Ayurvedic conditions in relation with doshas. It is Ayurvedic interpretation of HRV indices offer great opportunity to establish a novel objective test for enriching practice of integrative medicine. For this, we worked on HRV card protocol. It consisted of 15 minutes of supine rest followed by 5 minutes of standing without support and 1 minute of deep breathing. The ECG sampled about 1,000 samples per second and continuously through chronovisor tele-HRV ambulatory device. And HRV is then analyzed as per standards, and then the diagnosis are assigned independently by Ayurvedic clinician and modern clinician. This is the HRV device which runs on 3 simple batteries and continuous ECGs run all through the time of 25 to 26 minutes. Sample consisted of 102 patients in age range of 26 years to 81 years. HRV indices of overall variability, SDNN, and total power, FFT, correlated with Vata Vikruti, and while LF4 is correlated with Pitta Vikruti. The post-treatment results showed reversal of the initial dysfunction of both clinically and by HRV, and also support the concept of establishing balance. These are the indices and dosha patterns identified as per LF, HF, LFHF ratio, and power. This is the case study which I am going to show here. This is very peculiar. It was a coronary artery disease patient admitted at very important institute in Mumbai, and bypass surgery was planned, but luckily RT-PCR came positive in the morning, and the surgery was postponed. This is the complete report. You can see the in post-treatment, SBNN is in normal range. All other indices are in normal range. These are other cases which where pre-treatment and post-treatment indices fall in normal range. In short sample of the result, these are the various conditions which are treated as per HRV indices. The conclusion is HRV can be assigned to weak interpretations meaningfully and provide quantitative measure for Vikruti or disorders. So, this is a small presentation from us. Thank you.
Thank you, sir, for wonderful presentation. I have just a few questions that what is your clinical experience in your day-to-day clinical practice? Do you find all these doshas correlate with this HRV pattern?
Yes, I'm using this HRV technology from 2017.
Okay.
And almost 102 cases I have recorded.
Oh.
And according to that, it is very easy to take decisions when actually difficult cases or patients are referred from various doctors, or difficult cases can be analyzed very easily with HRV modulation. That helps me.
Okay, thank you, sir. Thank you for your wonderful presentation. So we'll
fundamental, you can say, investigations or the fundamental indices. As we know, autonomic nervous system is a very fundamental system. It could be pathy agnostic.
Yeah.
There's nothing to do, with either the allopathy or the Ayurveda or any other system of medicine. This is something which is a very fundamental basic physiology, and which perhaps many people could interpret in their own ways. And so far as it helps them make clinical decisions. Of course, the proof of the pudding is in eating, and if he says that it helps him, it helped him. As he said, that we are actually happy about that. So the basic infrastructure, the whole conference, sort of discussing the paradigm of PNI, psycho-neuro-immune endocrinology, seems to be pathy agnostic in that sense, which perhaps everybody should follow. And that would actually allow us better implementation of mind-body medicine. Otherwise, as we know, that it becomes difficult. The crosstalk becomes difficult. When we try to say interact with the application of yoga and meditation, the crosstalk becomes possible only if we are talking within this fundamental paradigm of PNI, where we clearly understand the neurobiological effects, and we are able to a common language, sort of between us and other ones. Thank you so much.
Thank you, sir, for your comment. Okay, so now we'll move on to the next presentation by Dr. Dharni K. She is from Srihar Institute. It's Sri Ramchandra Faculty of Allied Health Sciences, Srihar, Purur, Chennai. So she will be presenting on the effect. So these are the e-posters. The effect of dinner habit on sleep hygiene among general population. So you have the time limit of just 2 minutes and 1 minute for comment or discussion.
So hello everyone and good morning to everyone present here. I'm Dharni. I'm from Department of Mind Body Medicine and Lifestyle Science. I'm Sri Ramchandra Faculty of Allied Health Science, Srihar, Chennai. So my topic will be effect of dinner habit on sleep hygiene among general population. So my objective is to study how dinner and its factors associated with affect the sleep hygiene among the general population. So the background will be the sleep disorders, insomnia, narcolepsy, and restless syndrome, etc. And age. So the more you get age, the sleep disorders will be occur. So more specific, when you're getting older than 60, you have a sleep trouble sleeping. So gender, women have more quality sleep, and also they have more sleep related problems. So next, causes of sleep disorders are medication and your studies, workload and caffeine, nicotine. So workload and studies overload will get more effect on sleep. So methodologies have searched the articles from PubMed and Google Scholar, and inclusion criteria will be the full text and a free full text, and the article should be in English. So the keywords will be sleep disorder, and dinner time and dinner. So the results of my study was I have reviewed many articles. So review of a published report shows that the late night dinner leads to GERD, that is gastroesophageal reflux, and oily and spicy foods will cause rise in body temperature and delays gastric emptying, and it will lead to trouble sleeping. And association of sleep quality and quantity of the food you intake will leads to cardiometabolic diseases. And conclusion will be unhealthy eating and unusual time will lead to sleep worsening. So when evaluating your sleep,
Your time is up.
thank you.
So it was not conclude in one line. Yeah. You can conclude in one line.
So when eating, you should consider the quality and quantity of the food and timing.
Thank you, ma'am. So the next presenter is Dr. D.P. Hariprita. She will the doctor will be presenting on the effectiveness of the mind-body technique in improving self-esteem among women with polycystic ovarian syndrome. She is also from Srihar Institute. Over to you, ma'am.
So good morning to one and all present here. So my topic is effectiveness of mind-body technique in improving self-esteem among women with polycystic ovarian syndrome. So we all know that PCOS women have their many clinical systematic manifestations of cysticism and negative body image, and they also have low self-esteem because of those negative symptoms like obesity and many other things like cysticism and oligomenorrhea and infertility. So all of this can cause lower self-esteem to PCOS women. So my objective is to assess the self-esteem among women in PCOS and to assess the effectiveness of motivational interviewing in improving the self-esteem among PCOS women, and also to assess the meditation like loving kindness meditation, which can help, which can also enhance the self-esteem like self-care in the woman with PCOS. So here are the, I just included that how PCOS impacted the hypothalamus pituitary axis and how meditation has effect on improving self-esteem on amygdala, limbic system, that for improving the well-being and also lowering the stress. And there I have included a motivational interview effect on the vasomotor cortex and dorsolateral prefrontal cortex in improving the reward system, which can also improve the self-esteem. So, so my methodology is through the search engine of PubMed, Google Scholar, and Science Direct. I have found that there are 2,966 articles, and where I have filtered many articles that have shown that motivational interview and has improved self-esteem in diabetic patients and in cardiac patients, and also meditation also have increased the self-esteem among cancer patient and all. While doing many meditation, they have improving their self-esteem. And I also found that there are 490 articles stating that PCOS population has lower self-esteem and also negative body image. So concluding with this, my self-esteem can be improved by psychotherapy and many other therapies. But the lacuna here, I found that how effectiveness of motivational interview and loving kind of meditation or any kind of meditation in improving the self-esteem among PCOS.
Thank you, ma'am. Yeah. Our next presenter is Dr. Mahalakshmi Krishnamurthy. She will be presenting on the effectiveness of relaxation techniques in diabetes control. She is also from the same institute, Srihar Institute, Chennai. Over to you.
Good morning, all. First of all, thank you for this wonderful opportunity. I'm Mahalakshmi from Srihar, pursuing my mind, body medicine, and lifestyle sciences. So I'll be presenting on effectiveness of relaxation technique in diabetes control. So as we see, diabetes is a dreadful chronic metabolic disease. So there are, if you see diabetes, there are modifiable. The cause of diabetes is multifactorial. So there are modifiable factors and non-modifiable factors. In we will be stressing about the modifiable factors, such as lifestyle management, stress control, and hormonal imbalance. So according to WHO, it has been predicted that by around 2030, it would be around 366 million people will be affected due to diabetes. So objective is that to analyze the effectiveness of relaxation techniques in diabetic control and to compare the different relaxation techniques to control diabetes mellitus. So through my literature search, I have reviewed articles regarding mindfulness-based stress reduction technique, yoga, diaphragmatic breathing, and progressive muscle relaxation. Why I have chosen this four technique is that it has been widely used and most commonly used technique and has been found the most positive changes in overall psychosocial profile of the patient. So here the after the interventions is been given, the progressive muscle relaxation is that we will be carrying this up to at least 8 weeks to see the positive changes among the patients. The MBSR includes the mindfulness meditation as well as the series of Hatha Yoga. There will be a both mind and body interaction such that there will be a positive changes in the overall profile of the biopsychosocial model. So to list some of
Can you conclude in one line because
so in the
time is
future
up.
studies, there should be like both the lifestyle modification and along with these the mind-body therapies as to go in head to head to see the positive changes among the individuals and also to decrease the burden of the disease.
Thank you, ma'am.
It was wonderful.
Thank you. Nice presentation. So the next is Dr. Pratibha S. I think doctor is there. Dr. Pratibha S.
Yes, sir. Good morning. Good morning to one and all. I'm Pratibha, doing masters in mind, body medicine and lifestyle sciences. And my topic is to discuss about the effects of Ujjayi pranayama and hypothyroidism patients. And as we all know, it is one of the most common endocrine or endocrine disorders, and also epidemiological burden in India and around the world. My background would be to study the pranayama techniques, especially Ujjayi pranayama, which is a slow breathing technique. And my methodology would be on, I found the articles on PubMed and Google Scholar, and the results are derived from that. And I chose to compare Ujjayi Pranayama and Surya Vedana because both seems to be effective in the treatment of hypothyroidism. And I found that Ujjayi Pranayama seems to be more appropriate for introducing modalities in hypothyroidism patient, as it doesn't increase or affect the BP, but Surya Vedana tends to increase it, and the effects of Ujjayi Pranayama techniques that has been followed for 6 months or so has shown the following physiological effects that are observed in the studies. And my conclusion would be on Ujjayi Pranayama is very effective in hypothyroidism patients, but more like experimental studies have to be done with more larger sample sizes and follow up larger follow-up times. So my future scope would be to integrate alternate therapies like Ayurveda, Siddha, and yoga, and also necessary lifestyle changes to foster better management in the hypothyroidism patients. Thank you.
Thank you, ma'am, for a nice study. It's very important that this type of pranayama can improve the thyroid dysfunction. So our next presentation is by Dr. Mansi Sharma. She'll be speaking on the mindful eating for overweight and obese adolescents. And she's also from the same Srihar Institute. Over to you, ma'am.
You can start.
So, hello everyone. My name is Mansi Sharma, and I'm from Chennai, studying in Sri Ramachandra Medical College, pursuing my PG first year in mind body medicine. So, my topic is on mindful eating for obese adolescents. Why obese adolescents? Mainly because, as we can see, adolescent children are not, adolescents are not mindful while eating, because as you can see, this is the age where they socialize the most, and food becomes the major factor of bonding. Like while they go out and when they socialize and when they share food, that's how they bond, right? So they do not watch what they eat. And my aim here is to study the improvement of adolescents' relationship with food and enable changes towards successful weight regulation. The background is overweight, obesity are important public. It's a major concern. Obesity is a major concern, not just in adults but also in children and adolescents. So it is proven that if the obesity is when the obesity is in adolescent, when it's in adolescent, they tend to mainly it affects their self-esteem, their confidence level, their body image, and their depression, anxiety, which is why the mindful eating, the flow chart comes in place. It mainly focuses on why they are eating. Are they eating because they're bored? Are they eating because they are hungry? And where they are eating, the environment, are outside, because they tend to eat more when they are out. And what exactly they are eating, how they are eating, are they eating too fast or they eating too slow? Because it's proven that you're supposed to chew it at least 32 times. And how much they are eating, the quantity is very important. And the mechanism, we can see that there are many physiological and psychological changes when they are being mindful while eating. It obviously reduces weight, and it increases awareness of hunger and satiation, like how are they really hungry or they full, because this is the main question which you're supposed to ask before eating. And I would like to conclude it with since the new lifestyle modification here, all the adolescents are deviating to the wrong path of the food eating habits. So it is very necessary, in order to avoid the metabolic disorders in later life. You're supposed to eat food mindfully and pay attention on what is going inside your body, because your body is a temple and you need to worship it.
Yeah. Thank you,
It
ma'am,
was
for
excellent.
the nice
It was excellent
presentation.
Thank you.
Our next speaker is Dr. Somila Asif. She will be speaking on the amisulfuride, second generation antipsychotic with an OHA-like action. She's from Department of Psychiatry from the Kalinga Institute of the Medical Sciences, KIMS, Bhubaneswar. Are you there, ma'am?
Yes. Good morning, everyone. Today I'm here to share a poster titled Amisulfuride and SGA with an OHA-like action. Through this poster presentation, I'd like to highlight 3 cases which we encountered in our clinical practice. And all these 3 cases were aged around 40 to 60 years and required antipsychotic for the management. And their baseline investigations revealed pre-diabetic levels. So we preferred amisulfuride as the antipsychotic because it is known to cause least metabolic side effect among the other drugs. And surprisingly, after 1 month, and in one case after 3 months of follow-up also, we found that not only the psychotic symptoms showed improvement, but the blood parameters, the blood glucose level, fasting blood glucose level, and PPBS levels, they also showed significant improvement. So my conclusion would be to generate a hypothesis that whether amisulfuride, which is a second generation antipsychotic, can serve like an OHA. And I would like to say that it needs a well-designed systematic RCT to substantiate this finding further. Thank you.
Thank you, ma'am, for a nice study observations in these 3 studies. So, whenever the patient is diabetes or with the psychiatric disorder, we can definitely consider this one of the molecule to start with. So, we'll move on to the next presentation by Dr. Samiksha Khade. She will be presenting a case, Sheehan Syndrome. She is from the Department of the General Medicine, MGM Medical College, Aurangabad.
Good morning, everyone. I'm Dr. Shamisha Khade. I'm a final year resident in the Department of General Medicine, MGM Medical College and Hospital, Aurangabad. Today, I'll be presenting a case on Sheehan Syndrome. As we all know, Sheehan Syndrome is a form of maternal hypopituitarism, which is caused due to extensive hemorrhage during or after delivery of a baby that may affect the function of pituitary gland. It is an extensive bleeding which may lead to decreased blood flow to the pituitary gland and cause ischemia to the pituitary gland, causing infarction or necrosis. It has been estimated that Sheehan syndrome may occur in around 5 out of every 1 lakh women giving birth. Its incidence is lesser in developed as compared to developing countries. Sheehan syndrome is usually a missed out diagnosis, and hence we are reporting a rare case of Sheehan syndrome which we had. A 43-year-old female married since 20 years had come to MGM hospital with complaints of loose stools vomiting. So the symptoms are suggestive of acute gastroenteritis, for which she was treated over a span of 3 days, and she completely recovered from that. But on further inquiry, patient's relatives also complained of slowness of speech, movements, which had progressively increased over 15 years, around 12 to 15 years, but they had ignored the symptoms. Patient also had history of amenorrhea since 15 years, since the last pregnancy. During the last pregnancy itself, she had history of postpartum hemorrhage and was hospitalized in the ICU for around a week for the same. Since that, she also had a failure of lactation in the postpartum period. On examination, patient was otherwise vitally stable, but she had loss of axillary pubic hair and thinning of scalp hair along with hypogonadism. The systemic examination was also within normal limits, except for the fact that the deep tendon reflexes after eliciting had decreased, had a prolonged time for relaxation. Patient was evaluated for the slow speech, dry skin, sparse hair, and axillary hair, along with the help of laboratory investigations. Basic TSH and T3, T4 levels were done, which were suggestive of a central cause of hypothyroidism, since all 3 were low. After that, she was evaluated with other hormone levels for the central evaluation of pituitary cause.
Thank you so much. Yeah, your time
actually,
is
your
up.
time is up, ma'am.
Yeah.
Thank you for
It was
nice
wonderful.
presentation.
Yeah.
So we'll move on to the last presentation by Dr. Soumya Vaikar. She will be talking on the hypochondriac behavior among the women with PCOS. She's from this Srihar Institute, Chennai. Over to you, ma'am. You can start.
Good morning, everybody. I am Soumya J. Vaikar, a postgraduate student in the Department of Mind Body Medicine and Lifestyle Sciences at Srihar, Chennai. I'll be talking about hypochondriac behavior among women with PCOS, and the objective of the study was to understand the relationship of hypochondriasis in women with PCOS and how it affects their management and prognosis. So the background is hypochondriasis is a preoccupation with one's health, and in the recent times it's turned to cyberchondriasis, which is Googling our symptoms or worrying about our symptoms and our diagnosis because of the information or the literature available online. This is what we commonly term as Google patients, and like it was spoken yesterday in a couple of talks about patients going doctor shopping. This would in terms be of patients going doctor shopping or health shopping in general to try out anything that's available just to make them feel more comfortable with the diagnosis and the management that they're receiving. And PCOS is one of the most common endocrinopathies that we know, which has symptoms ranging from both irregular cycles to as far as infertility. And the most common intervention would be contraceptive pills, metformin, and hormone therapy. The methodology we did was we did a bibliometric analysis in databases like PubMed and Google Scholar with keywords like PCOS, hypochondriasis, cyberchondriasis, and health behavior. The results was that we identified diagnostic challenges, delayed diagnosis, less than optimal treatment regimen, and a lack of satisfactory treatment options as felt by both the physicians and the patients receiving it. There was a gap identified among the practicing physicians and OBGYN residents that there are significant deficiencies in the knowledge of the diagnostic criteria for PCOS. And in PCOS women, this leads to hypochondriasis and worry and stress, which affects the quality of life. So the future direction of this would be that we try to bridge the gap, and here is where a life coach, life or a health and wellness coach comes into play, when they bridge the gap between the physician and the patient by including lifestyle interventions and by using techniques like motivational interviewing, so as to improve the bring the patient from pre-contemplation and worry about their condition to taking actions and setting smart goals to achieve their health goals and be on a better health journey, so that their PCOS outcomes is improved. Thank you.
Thank you, ma'am. Thank you for finishing in time. So I will hand over a session to Dr. Sonali, ma'am, for the further proceeding. We conclude this session of paper and poster presentation. Thank you.
Thank you, Dr. Harale, for moderating the session very well, and also to all the presenters and the postgraduate students for presenting very insightful posters, which can be very well used in our clinical practice, to be specific. So yes, we end our session here.